This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Child's Nervous System, published in 2026. It's a retrospective observational study comparing the management and long-term outcomes of adamantinomatous craniopharyngioma, or ACP, across two major international pediatric centers.
This is a topic that hits home for any pediatric neurosurgeon. ACP is an uncommon and, frankly, anatomically variable tumor. We are constantly walking that razor's edge, the pursuit of a gross total surgical resection versus the risk of devastating hypothalamic injury and the ever-present threat of tumor recurrence.
Exactly. And what makes this paper unique is the comparison between two very different cohorts, Great Ormond Street Hospital, or GOSH in the UK, and the Universidade de São Paulo, USP, in Brazil. They looked at 123 patients in total, 71 from GOSH and 52 from USP, treated between 1997 and 2023.
That's a significant time frame and a robust sample size for such a rare pathology. Before we dive into the outcomes, Ilara, what did the baseline characteristics tell us about these two populations? Were they comparable?
Demographically, yes. There were no major differences in age or sex. However, the clinical presentation and tumor morphology were surprisingly distinct. In the USP cohort, patients presented with much higher rates of growth hormone deficiency, 62.5% compared to only 35% at GOSH. Visual deficits were also significantly more prevalent at USP.
That suggests either a delay in presentation or perhaps a different biological behavior in those tumors. Did the imaging reflect that?
It did. The USP tumors were predominantly solid, 75% of them, whereas at GOSH, 76.7% of the lesions were predominantly cystic. Furthermore, the GOSH cohort actually had a higher Paris grade for hypothalamic involvement at presentation.
That's an important detail for our residents listening. The Paris grade is vital for staging the degree of hypothalamic contact or invasion. So we have GOSH dealing with more cystic tumors that have higher hypothalamic involvement and USP dealing with more solid tumors and worse baseline functional deficits. How did the surgical management differ?
This is where it gets interesting. While the rates of gross total resection, or GTR, were actually similar between the two groups, the philosophy of subtotal management varied. At GOSH, they were much more likely to use cyst aspiration plus radiotherapy. At USP, they leaned more towards surgical debulking.
That reflects a classic debate in our field. Do you aspirate and radiate to minimize surgical trauma, or do you physically debulk the mass? The paper notes that GOSH's approach led to some interesting functional outcomes, right?
Yes. Despite having higher hypothalamic involvement at the start, the post-treatment hypothalamic scores were actually better in the GOSH cohort. This suggests that their management strategy, perhaps being more conservative with the hypothalamus and utilizing radiation, was effective in preserving functional integrity.
Let's talk about the elephant in the room for craniopharyngiomas, recurrence. If GOSH was more conservative, did they pay for it with higher recurrence rates?
The data shows that GOSH patients had earlier recurrences, averaging about 25.5 months compared to 37.4 months at USP. This was a statistically significant difference.
So, the trade-off was better hypothalamic preservation but a shorter interval to recurrence. It's the classic craniopharyngioma dilemma. Did the study look at what factors actually predicted longer progression-free survival across both groups?
They did a multivariate analysis, which is the gold standard for this kind of data. They found two primary factors associated with longer progression-free survival. First, the extent of surgery, having either a subtotal resection, or STR, or a gross total resection, or GTR, was protective, with an odds ratio of 0.17. Second, older age at diagnosis was associated with better outcomes.
Older age in a pediatric context is always relative, but it's a consistent finding in ACP literature. Let's dive deeper into the hypothalamic injury aspect. For the residents listening, why is the Paris grade so emphasized in this study?
Because it's the primary driver of quality of life. The study evaluated functional outcomes related to pituitary function, hypothalamic injury, cognition, and vision. While GTR is the goal for oncological control, the authors mention that the balance is difficult. The fact that GOSH achieved better post-treatment hypothalamic scores despite worse initial involvement highlights that surgical radicality must be tempered by the tumor's relation to the optic apparatus and the hypothalamus.
And that relationship was independently reviewed in this study. They didn't just take the surgeon's word for it, they had scans reviewed for tumor size and characteristics. It's also worth noting the mean follow-up times, over 10 years at USP and 7.5 years at GOSH. In the world of ACP, you need that kind of decade-long data to really understand the outcome.
Absolutely. Craniopharyngiomas are notorious for late recurrences. One thing that struck me in the results was the difference in the solid versus cystic nature. Why do you think USP had so many more solid tumors?
It's hard to say without molecular data, but it influences the surgery significantly. Solid components are often more adherent to the small perforating vessels of the circle of Willis and the hypothalamus itself. Cystic components can often be drained, which provides immediate decompression of the visual pathways, but as GOSH found, they might recur sooner if the cyst wall isn't fully managed or radiated.
The study also points out that while radiotherapy was common at GOSH following aspiration, the USP cohort's reliance on debulking might explain their longer time to recurrence, even if it meant more initial surgical manipulation.
It really highlights the two different schools of thought. One school prioritizes the functional hypothalamus at all costs, accepting earlier recurrence as a manageable trade-off. The other school prioritizes maximum safe debulking to push that recurrence as far into the future as possible.
And the multivariate analysis really drives home that age and the degree of resection, whether STR or GTR, are the heavy hitters. If you're a trainee, the takeaway is try to get as much as you can without crossing the line into hypothalamic injury.
Easier said than done when you're in the third ventricle. Now, Ilara, before we wrap up, were there any specific visual outcomes mentioned?
Yes, they noted that visual deficits were higher at USP at presentation, which aligns with their higher rate of solid tumors. However, both centers focused on the importance of the relation to the optic apparatus during the independent scan reviews.
This paper is a great reminder that neurosurgeon isn't practiced in a vacuum. International series like this show us that even with the same disease, different clinical presentations and management philosophies can lead to different but equally instructive outcomes.
It's a call for personalized treatment. For a predominantly cystic tumor with high hypothalamic involvement, the GOSH model of aspiration and radiotherapy might be superior for quality of life. For a solid tumor, the USP model of more aggressive debulking might provide that longer progression-free interval.
Well said. To our listeners, the key takeaway from Yamaki et al. Is that while GTR, STR, and older age favor progression-free survival, our primary duty remains the preservation of the hypothalamus. The Paris grade is your best friend in preoperative planning.
Thank you for joining us on the Neurosurgery Hub podcast. You can find the full paper, Long-Term Outcomes of Pediatric Craniopharyngiomas, a comparison of 2 large international series, in Child's Nervous System.
Until next time, keep learning and keep operating with precision. I'm Dr. Aris.
And I'm Dr. Ilara. See you in the next episode.